All right, let's talk about a scenario that can definitely keep you on your toes in late-stage pregnancy, managing an unstable fetal lie. Today, we're going to walk through a really clear, step-by-step clinical pathway to bring some order to this pretty complex topic. So, here's our game plan. We're going to follow the whole clinical journey, right from the beginning. We'll start by pinning down a solid definition, then move through the prenatal assessment and management options. After that, we'll tackle the really critical interpartum period. And finally, we'll close the loop with what to do postnatally. Okay, first things first. Before we can manage this thing properly, we all need to be on the exact same page. So let's get the fundamentals right and start with a really clear definition of what an unstable lie actually is. So the key takeaway here is the timing. This is happening after 37 completed weeks. The fetus just hasn't settled into that final, stable, head down or breech position. It's still moving around, shifting between transverse, oblique, you name it. And it's that constant change, that instability, that creates the whole management challenge. Okay, so you think you might have an unstable lie on your hands. What's next? Well, we move into a systematic prenatal assessment. This is a two-part mission. First, confirm the diagnosis, and just as important, figure out if there's an underlying reason why. Clinically, you're going to start with a really deep dive into the patient's history. You're basically hunting for red flags, things like polyhydramnios or any abdominopelvic tumors. A pelvic exam is also key to check out the anatomy. But, and this is crucial, before you do much else, you absolutely have to exclude placenta previa. And this is where ultrasound really shines. Look, it's not just an adjunct tool here, it is the primary investigation. It nails down the diagnosis, confirms the lie, and helps you hunt for those causes we just talked about, malformations, tumors, or confirming that placenta previa. And let's be clear, in this day and age with ultrasound available, X-ray really has no place in this workup. All right, so you've confirmed it's an unstable lie. Now you're at a fork in the road. Before labor even kicks off, you're faced with a big choice. Do you go with a non-interventionist, watchful waiting approach? Or do you jump in with a more active, hands-on plan? This really lays out the core dilemma, doesn't it? On one side, you have non-intervention. You're banking on the fact that about 80% of the time, the baby will turn on its own. Of course, this means some serious counseling about the risks, like cord prolapse. On the other side, you have active intervention, which usually means hospitalization for close monitoring, so you can act at a moment's notice. And here's the magic number, 37 weeks. This is the key milestone. It's the point in gestation where the risks really start to ramp up, and it's typically when we start initiating those active management protocols, like admitting to the hospital. Now, if you do decide to go the active management route, you've got three main tools in your toolbox. You can try to manually turn the baby with an external cephalic version, or ECV. You could go for something called a stabilizing induction, or in certain cases, you might just plan for an elective C-section. So let's take a closer look at a stabilizing induction. It's a really carefully choreographed sequence. First, you do an ECV to get the baby longitudinal. Then, you start a little oxytocin to get some contractions going. Once those are established, you do a low amniotomy, which helps the head engage in the pelvis and basically locks in or stabilizes that lie. Now, there's another way to do this, a variation on that theme with one really key difference. After you've done the ECV and started the oxytocin, instead of a low amniotomy, you use a special tool called a Drew-Smythe catheter to do a hind water rupture. It's a more controlled release of fluid from higher up, and the idea is that this can lower the risk of a cord prolapse. We talk about ECV a lot, it's a cornerstone for sure, but we've got to be realistic. The success rate isn't 100%. It kind of varies, sitting somewhere between 40 and 65%. And that variability is exactly why you have to have those other options, like C-section, ready to go. So an elective C-section isn't where you start, but it absolutely becomes the necessary and safest path in these very specific situations. If ECV is contraindicated, or if you tried it and it failed, if there's some kind of mechanical blockage, or of course, if you've got a placenta previa. Okay, let's shift gears to the most time-sensitive, high-stakes part of all this, managing the patient who shows up already in labor or with her water broken. This is where you have to make the right calls, and you have to make them fast. When that patient comes in, there is one question that trumps everything else. Right now, in this moment, what is the fetal lie? Seriously, the answer to that one question dictates your entire immediate game plan and tells you if you're dealing with a normal labor or a full-blown obstetric emergency. And this right here is that decision tree in action. It's a true fork in the road. If the lie is longitudinal, great. You can proceed with a cautious but pretty normal labor management. But if it's non-longitudinal, that triggers an urgent protocol. You assess the baby, you check for a cord prolapse, and you try an immediate ECV. If that doesn't work, you're heading for an emergency C-section. Let's be crystal clear about this because it's so important. If you discover a cord prolapse when you have a non-longitudinal lie, this is a true, no-kidding obstetric emergency. There's no other maneuver, there's no other option. The only answer is an immediate C-section to save that baby. But hey, our job isn't done just because the baby is delivered. There's a final crucial step, and that's the postnatal conversation. You have to counsel the patient about what this means for any pregnancies she might have down the road. And here's why that conversation is so critical. Not all C-sections are created equal, right? The type of incision on the uterus makes a huge difference. A low transverse cut has different risks than a classical one. So if a classical C-section was necessary, it is absolutely our duty to give that patient explicit guidance on how future pregnancies should be managed. And that leaves us with this really fundamental question for our clinical practice. On the one hand, we know most of these babies will turn on their own. But on the other, we know the risk of a cord prolapse is catastrophic. So does that potential for a severe complication mean we should shift towards active management as the default, the universal standard of care for every case after 37 weeks? That's a huge debate in obstetrics today.